Hello and welcome to Workers' Comp Unwrapped, the podcast that simplifies workers' compensation for physicians. So, let's get started. Welcome to Season 3, Episode 20 of Workers' Comp Unwrapped. I'm Anik, your host.
And I'm Angela. It's great to be here.
We are so glad to have you. With 15 years in this industry, your insight is exactly what we need for today's topic, which is, let's be honest, a bit of a monster.
It really is.
We're talking about long COVID billing in 2025, specifically these prolonged disability cases and the persistent coding gaps. Our mission today is to explore how these high-cost, long-duration cases are still creating so much billing confusion.
And more importantly, how you can learn to protect revenue and really reduce that denial risk.
Exactly. So for our listeners, what's the core problem we're unpacking here?
I'd say the core problem is that long COVID files are a perfect storm. They're multi-system, they are incredibly documentation heavy, and they are authorization hungry. That combination is a recipe for billing confusion and, frankly, a lot of friction in your AR.
A perfect storm indeed. Okay, so we're going to break it all down. We'll start with what's compensable now that the old rules are gone, how to code this complexity, and how to navigate the whole UR maze when there isn't really a rule book.
And we'll finish with the 6-point blueprint, a practical guide to keep those authorizations moving and protect your billing.
Let's do it. Okay, let's start with, I guess, a reality check. For a few years, everyone had these COVID presumptions, things like California's SB 1159. They made things faster.
That's faster.
But now, for most workers, those are gone. So what's the new normal? What happens to a long COVID claim that, walks through the door today?
Well, the game has fundamentally changed. The key shift is that long COVID now has to be proven industrial through the standard A or ECOE process.
We're rising out of employment and course of employment.
Exactly. There is no automatic assumption anymore. The burden of proof is right back on the claimant to show where and how they were exposed at work.
And what's the immediate consequence of that? I mean, for a provider dealing with a patient who's been sick for, say, 18 months.
The consequence is immediate operational paralysis. I mean, as soon as compensability is under investigation, what happens?
Everything stops.
Everything stops. Authorizations for diagnostics, payments, it all just gets delayed. And that creates this massive financial lag right at the very beginning of the case. These aren't simple injuries.
Right.
They need complex studies. So the claims just sit there in limbo for much longer than a typical claim.
Sounds like a logistical nightmare, not just a legal one.
Yeah.
So the takeaway here for a provider isn't really about arguing in a courtroom.
No, not at all.
It's about giving the claims administrator the information they need to speed up their own decision.
Exactly. You are building the bridge for them. You have to give them what they need to approve it quickly. Your initial documentation has to be pristine. A clean narrative of the exposure, a precise timeline of the symptoms, and objective findings that link everything to the functional impact.
So, how it affects their ability to do their job.
Yes, if you deliver that up front, you can cut weeks, maybe even months, off that investigation. And that means treatment gets approved faster, and your billing timeline is protected from day one.
It's a virtuous cycle then. Clean paperwork means the money flows faster. Sloppy paperwork
Means the claim sits in the adjuster's to-do pile forever.
Okay, so let's say compensability is locked down. The next massive headache is trying to communicate the clinical reality of this illness to the billing system. Which brings us to coding. The main ICD-10 code exists, but that's just the start.
Oh, it's barely the start.
And this is where it gets really interesting because the complexity of the patient has to be perfectly mirrored by the complexity of the bill.
That's absolutely essential. The main code, U09.9 post-COVID-19 condition, it's a guaranteed recipe for denial on any complex request if you use it alone.
Just by itself.
Just by itself. Utilization review, or UR, will not authorize complex multidisciplinary treatment based only on U09.9. It's just too vague. It doesn't specify what you're actually treating.
So we're talking about mandatory code stacking. You have to paint the full picture. What are the common codes that really have to be in there?
You need to show the true functional deficits. So you have to include the R06 series for, dyspnea, any respiratory trouble. You definitely need R41.3 for cognitive impairment, what everyone calls brain fog. And this is important. You have to differentiate the types of fatigue. We see R53 a lot for general fatigue, but for that chronic debilitating fatigue, you need to be using G93.3 for post-viral fatigue syndrome.
That distinction feels crucial. But if I, as the provider, stack both R53 and G93.3, how do I stop a reviewer from just flacking that as, aggressive upcoding?
That is a fantastic question. The safeguard is objective measurement. You can't just list the codes, you have to show the proof. For G93.3, you need standardized fatigue assessments. For R41.3, you need actual cognitive testing results that map the impairment.
So the documentation justifies the codes.
The documentation justifies the codes.
Yeah.
And we can't forget the other systems.
Right, the emotional and physical toll.
Absolutely. So we're talking about the F43 series for behavioral health anxiety, PTSD, and the M79 series for pain disorders. A clean, multi-system diagnosis list supported by objective tests, it's essential. It stops UR from assuming the case is mild, and critically, it supports higher-level EM billing.
Which brings us to the core operational challenge, getting authorization. In a place like California, you've got MTUS, the Medical Treatment Utilization Schedule. It's the rule book.
It's supposed to be, yes.
But it was written for traditional injuries. There's no chapter for long COVID. So how does a provider get anything authorized when the rule book is just silent on the topic?
It's fascinating, actually, to see how reviewers have to get creative to compensate for that. They're essentially playing Tetris with the rulebook. They're trying to fit this multi-system square peg into a single injury round hole.
So they don't just deny everything out of hand.
No, they try to use existing MTUS chapters that best fit the patient's dominant symptoms. If it's mainly respiratory, they'll pull the respiratory chapter. If it's chronic pain, they'll use that one.
I see.
And when MTUS really is no help, they revert to external guidelines, from ACOM, AHRQ, the CDC, reputable evidence-based sources.
Okay, that raises the single most important question for anyone submitting an RFA, a request for authorization then. How do you justify care in this patchwork system and avoid an immediate denial?
Your documentation has to be the translator. It must explicitly tie the patient's symptoms to their functional limitations, to the guideline-based reason for the treatment you're requesting.
Can you give me an example of that?
Sure. If you're asking for cognitive rehab, the RFA needs to say something like, per AHRQ guidance on long COVID and based on the R41.3 diagnosis confirmed by a MoCA score of X, we require Y sessions of cognitive therapy to achieve the functional goal of returning to complex data entry.
And if that connection is weak, if it just says, patient needs PT because they're tired?
UR will default to their favorite denial reason. Insufficient objective findings.
Of course.
They rely on it, because if they can't clearly map your request to an objective finding or a specific guideline, their only safe response is to deny or, give a very conservative approval. And this difficulty is exactly why so many long COVID cases end up at IMR.
Independent medical review.
Right. Not because the care is wrong, but because the justification is just so uniquely complex. The provider almost has to write their IMR defense in the initial RFA.
Okay, let's talk about the money, the cost reality. These are not short-term cases. They last a long time, often over a year, and they need so many different specialists. So what is it specifically that drives the extremely high cost?
It's the sheer breadth and frequency of the services. It's not one big-ticket item, it's 1,000 small ones that all add up over time. You start with repeated, expensive diagnostic studies, multiple specialist evaluations, pulmonology, cardiology, neurology.
Just to rule things out.
And then the ongoing therapy starts. That's where the cost really accrues.
Right.
We're talking high-frequency services like cognitive rehab for the brain fog, behavioral health for the trauma of the disability, and chronic fatigue management. And in really severe cases, you might even see extensive functional restoration programs being authorized.
It's a logistical nightmare.
Yeah.
You have one patient seeing a pulmonologist, a PT, and a psychologist all at the same time, all submitting their own RFAs.
And that's where the expense gets compounded. Think of the paper trail. A patient could have 6 specialists involved. The pulmonologist submits an RFA, the PT submits another one, the claims administrator has 14 days to respond to each.
2 separate clocks running.
2 separate clocks.
Yeah.
And if one RFA gets lost or denied because the justification was slightly different from another specialist note, the patient's progress stops, and the provider's revenue stream stops right along with it.
So because the symptoms fluctuate so much, you need steady, structured, and aligned documentation across all the different doctors just to keep treatment continuously authorized and paid.
Consistency is everything.
All right, this is the practical part, the blueprint. We've laid out the hurdles, compensability, complexity, coordination. What does this all mean for the billing process? We've got 6 core strategies to protect revenue. Let's start with strategy 1.
Strategy 1. Document the AOE COBE link clearly. This is your primary defense against those indefinite delays. You have to include the detailed exposure narrative, the symptom timeline, objective findings, clear work restrictions, all of it. You're giving the claims administrator what they need to say yes faster.
Which gets the ball rolling on everything else. Okay, strategy 2 addresses that UR mess we talked about.
Strategy 2. Build MTUS-style RFAs every single time. Even without a specific long COVID chapter, you have to apply the logic of MTUS. That means objective measurements, ROM, PFTs, cognitive test scores, and you have to show evidence of failed conservative care. And crucially, reference the closest relevant MTUS chapter or external guidelines.
If you don't connect those dots for them,
they'll hit you with insufficient objective findings.
Got it. Strategy 3 is the coding.
Strategy 3. Code the multi-system involvement properly. Your billing has to reflect the full complexity. Use U-Euro 9.9 plus all the specific manifestation codes we discussed. If you're only coding for fatigue but asking for high-level cognitive rehab, it's an instant mismatch. The codes have to justify the service.
And the coordination piece. That's where things can really fall apart.
It's the biggest operational challenge. Strategy 4. Track authorizations across ALL specialties vigilantly. One patient might have 5 or more RFAs out there at once. This is where revenue just leaks away missed deadlines, orphan RFAs that get denied and no one even notices. You need a centralized system to manage all of it.
You almost have to manage the whole care team, not just your own little piece.
You do, which leads to strategy 5. Prepare for IMR, because it's common. Structure your files to win at IMR faster. Submit complete records, highlight the objective findings, explain what happens to the patient's function if treatment is delayed. The real villain is usually documentation gaps, not IMR itself.
And the last one, for the provider's own efficiency.
Strategy 6. Use time-based codes correctly. These long COVID visits are extremely time-intensive. There's counseling, multi-system review, cognitive checks. You should be billing for that time with higher-level EM codes, but you have to document that time thoroughly to support the code. Detail exactly what you spent your time on.
So to synthesize this all really quickly, managing long COVID billing comes down to acknowledging just how unique it is. The complexity demands comprehensive documentation, precise coding, and that consistent MTUS-style justification.
And let's just reiterate the financial context. This is so important for billing teams. In the post-SB 863 environment, if UR denies treatment and IMR upholds that denial, that's generally not a lien opportunity.
Wow, so that really confirms that prevention is everything. You have to win the authorization battle up front with a clean RFA and a strong clinical story. There's no real second chance later on.
Exactly. The whole financial incentive is on getting that initial authorization. Long COVID claims are high cost because they affect multiple systems. If you build the clinical narrative the right way, focus on those objective findings and guideline alignment, you make it easy for the administrator to approve. Authorizations will follow.
That is a powerful takeaway. If the clinical story is sound, the revenue follows.
Yeah.
But looking ahead, one last thought here. These cases create massive AR balances just because they last so long.
They do.
How might any anticipated fee schedule adjustments in the near future reshape the AR strategy needed for these uniquely complex, high-duration cases in 2025? That's something for you all to mull over as you work through these files.
A very important question.
It is. Until next time, stay well informed. Thanks for listening to Workers' Comp Unwrapped. If you found value in today's episode, subscribe and share with fellow doctors. Stay informed and keep making a difference in your patient's care.